There's a lot of needs that come to mind, but two that I think stand out the most to me that might not be as well known. One is continuous glucose monitors. Even though they provide such a great benefit for patients and families, they're often uncovered by Medicaid around the United States especially. And even in Florida, even though Medicaid covers CGMs, they can determine which ones they're going to cover for patients. So even though, for example, the Dexcom G6 has come out with a lot of great benefits for families, Medicaid has decided they're only going to cover the G5 right now, which is outdated by now. Another one is psychological support. Type 1 diabetes is a chronic disease that requires 24/7 management, and this can make our patients feel isolated, can make them feel alone, burned out. So psychological support, behavioral specialists, they can really help our patients and their families with coping mechanisms and motivation, but they're often in short supply. It's really important to consider the individual patient and their needs, their goals, their expectations for the devices. So if we've got a patient who, for example, is an athlete or they really enjoy swimming, they might prefer a tubeless insulin pump, one that they don't have to take off in the water. Our young children with minimal insulin requirements, for them, pumps that have really small incremental changes in insulin, even some pumps go down to 0 units per hour for basal rates. Those are excellent for them. There's specific continuous glucose monitors that can share data real time to the guardians, to teachers. So those are really important for our youngest children who might not be able to tell others that they feel low. It's been such an exciting time in the technology world right now. There's so many companies working on hybrid closed loop systems, and this is excellent because it gives our patients a choice once all of these devices come out, that they can pick the ones that are most beneficial for them. And a lot of companies now are making their devices interoperable, meaning that they can work with devices from other manufacturers. So our patients will really be able to customize their device. They can pick a CGM from one company with the specific features that they want from that, and they can pick an insulin pump from a different company, hopefully in the future, that they can really pick the ones that give the most benefit. So for management right now, glucagon is only available in a powdered form that has to be mixed just prior to administration, which can be scary for a lot of families because they're already in that emergent situation. They're trying to mix the glucagon. There was actually a study about 2 years ago published in Diabetes Technology and Therapeutics where they simulated a hypoglycemic event. 13% of caregivers and 0% of acquaintances were able to correctly administer glucagon. 3 actually gave insulin instead. So we are so close now to a reusable glucagon pen that will make treating hypoglycemic emergencies so much faster and safer for these families. And with that in mind too, it even paves the way and puts us one step closer to having a dual hormone pump with glucagon and insulin because the glucagon will be stable. Diabetic retinopathy is the leading cause of blindness in young adults with diabetes. It is asymptomatic until vision loss occurs, but early intervention can prevent vision loss and prevent progression of the disease. Current guidelines say that we need to screen patients with type 1 diabetes 3 to 5 years after diagnosis, once they turn 10 or once they've reached puberty, whichever's earlier, and then we screen them annually. Current guidelines, current studies are showing conflicting evidence on how early we're seeing retinopathy in these patients, how often we're seeing it in pediatric patients. So we wanted to better study this in our population. So we used a digital non-mydriatic fundus camera. We screened patients, 500 patients aged 9 to 26 years old. And even though this camera is used mostly in adults, we found that 2% of our patient population, or 10 of the 500, had diabetic retinopathy. None was proliferative. None required treatment, which is really reassuring for our patients. But it is still important, and we're looking at barriers to receiving the care that they need and barriers to meeting the screening guidelines, and we're in the process of completing our manuscript now.